I am here at the 2018 HFA conference, and I think this is a good time to review some of the large unmet needs and the large global burden of heart failure. So the unmet needs that are being addressed at the conference and that are close to all of us are heart failure with reduced ejection fraction. So in heart failure with reduced ejection fraction, we have a broad armamentarium of therapy. But a major limitation there is that this therapy is not reaching to all the patients. So there have been a generation of very well conducted randomized controlled trials that have proven the benefit in terms of morbidity, mortality, and improved quality of life with multiple interventions in heart failure with reduced ejection fraction. But especially globally, access to care is limited, access to cardiologists is limited, and cardiology support is needed for primary care to appropriately provide heart failure specific care, to initiate and uptitrate drugs, to consider devices. So as the armamentarium broadens, and the theme of this conference indeed is moving into the future where we have more devices related to heart failure care, it is really important to ensure also that all patients have access to these beneficial treatments. Another major challenge that continues to be discussed is heart failure with preserved ejection fraction, where there is no evidence-based therapy, but we're learning that it's as common as heart failure with reduced ejection fraction and associated with similarly poor outcomes. There have been several trials that have not succeeded in proving a benefit from interventions, but we're moving toward devices that might reduce the pressure on the left side, for example, to relieve symptoms in HFpEF. And we're also considering the novel entity of heart failure with mid-range ejection fraction that will be debated extensively, has been today and will be over the next few days at this Congress, where the ejection fraction in mid-range EF is not normal, but at the same time there's no evidence-based therapy. Finally, the last major challenge is acute heart failure. Despite multiple trials in the last few years, there is still no evidence-based algorithms, treatments or interventions to improve outcomes in acute heart failure. And in the late-breaking trial session this morning on acute heart failure, there was a lot of focus on congestion, the difficulty in diagnosing congestion, the difficulty in appropriately treating congestion. So we're learning that perhaps if we can redistribute fluid through, for example, splanchnic nerve blockade from the thorax to the abdominal cavity, we might relieve symptoms without moving the patient into kidney disease, for example. And there are also novel devices, ultrafiltration, and devices that simply measure in and output in the cardiovascular system that improve our diagnostics and perhaps our ability to appropriately treat patients with acute heart failure.